On today's episode of the Dr. Geo Prostate Podcast, we welcome Dr. Jonathan Lischalk, a leading expert in radiation oncology. He formerly served as medical director of NYCyberKnife at NYU Langone's Perlmutter Cancer Center, and now leads the Genitourinary Cancers program in the Department of Radiation Oncology at MedStar Georgetown University Hospital. Dr. Lischalk specializes in treating prostate, lung, brain, and spine cancers using advanced CyberKnife radiosurgery, which delivers highly precise, targeted radiation with minimal impact on healthy tissue. With nearly 40 peer-reviewed publications, national leadership roles, and recognition as one of Washingtonian's top doctors, he brings deep expertise and a collaborative approach to cancer treatment. Let's welcome to the Dr. Geo Prostate Podcast, Dr. Jonathan Lischalk.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome, everyone, to yet another episode of the Dr. Geo Podcast. I am your host, Dr. Geo, where it is my pleasure, my intention, my passion to help you with your prostate health, things like testosterone, ED, and how do you live even better as you get older. My guest today is Dr. Jonathan Lischalk. I just learned the pronunciation. I think that was pretty good, right, John? Lischalk.
Nailed it.
And you know a lot about John, who we introduced prior to the recording. Before we begin, some touching points. Don't forget to go to the drgeo.com, Dr. Geo newsletter. There's a lot of information that I send via email once or twice a week that you're not going to get anywhere else. These are what to do, how to do things, the latest and greatest in all things related to holistic and integrative urology and so forth. So make sure you go to drgeo.com and sign up. Dr. Lischalk, such a pleasure to see you again. As you know, I forgot we met several years ago, right around COVID time or a little bit after. Well, COVID time was like a 4-year time span, but we met at a conference, and so nice to see you again.
Yes, thanks for having me. Yeah, it's COVID time makes everything a bit of a blur.
It does. And you can see it with children. For those that have children, you could see what the impact it had. My kids the 12-year-old was too young. But I see it I have a 20 and 19-year-old as well. You can see it. It's like, yeah, that time did a number, though I think they're fine now, but it did a number on them.
Yeah, that's tough.
Let's see. Radiation oncology. So let's take it from the top. My audience know, well, Dr. Geo, he's a naturopathic doctor. It's all about natural. I want only natural. That's why I love Dr. Geo. I hope they say that. I hope that's what they say. Naturopathic doctor, right? Why is that, right? So I thought about this, and I'm the one, I've been working with medical doctors since my career began in the early 2000s, Columbia, then NYU. And I'm the one saying, no, guys, I understand the concern and the lack of trust in some cases, but how about when it does work? Yep, there's a lot of dysfunction. We get it. I get it. Expensive, all kinds of, how about when it does work in urology? I find, I don't want to stay on my soapbox here for too long, but my experience dealing with prostate cancer patients, I've seen about 8,000 patients in my career. They've done everything. And external beam radiation was like, well, some things just don't make a lot of sense to me, right? Yeah, you want to kill the cancer, and sometimes that's what you have. I got that. Radiate the whole area, hitting a lot of tissue that is benign and possibly causing harm later on. Actually, I saw a study recently, John, that the rates of secondary cancers from radiation, external beam radiation, is not as high as we thought, which I never thought it was based on the numbers and the patients that I've seen. But back in 15 years ago, well, the rates of secondary cancers, bladder cancers related to EBRT. In any event, though, I don't want to hit healthy tissue. I've seen bladder radiation cystitis in men, and then they have urinary problems later on from the radiation. And it's just never made sense to me.
Yeah.
Obviously, in some cases, once again, this is what we have, and this is what you have for this particular case. SBRT, however, tends to be more focal. So tell us a little bit, and I had Jonathan Haas, Dr. Haas on in my audience, but just in case for those that haven't seen it, give me a little bit of an overview of what SBRT is and how it's different than other energies and technology out there in the radiation space.
Yeah, sure. I mean, great points. When I think about the landscape of radiation oncology over the last 50 years, you can kind of, or even let's look back maybe 20 or 30 years, you can think of advancements in radiation oncology kind of like advancements in your cell phone. The radiation equipment that we were using in the 90s is kind of like one of those block cell phones you find in old school BMW or something like that. Right. And now we have an iPhone where you can just surf the web and do whatever you want on your cell phone. And you've seen kind of the same advancements as you go through in radiation oncology. So you think about some of the folks that got treated with radiation in the 70s and 80s, we were kind of using equipment that was pretty primitive. Back then, we didn't have high definition imaging like an MRI that we have now. A lot of people were just drawing on an X-ray or to treat, and it was really not that sophisticated. And during that era, we had not great equipment, not great imaging. We weren't great at targeting where the radiation was supposed to go. And the equipment was not able to kind of verify and validate that the radiation was going where we wanted it to go. So you kind of have, if you think about a tumor like a ball, the radiation was this kind of larger space that was going around the tumor and not really precisely targeting just where the cancer was. Mm-hmm. So that's kind of where we started. And because of our inability to kind of target just where the tumor is, the radiation that was being delivered had to be delivered in small doses over a longer period of time just to make it safe, because this large cloud of radiation was going towards the tumor. And there was a lot of normal tissue that was nearby, and they can't really tolerate a large dose of radiation delivered over a shorter period of time. But as time has kind of gone on, we've been able to get better imaging with MRIs and PSMA PET scans. We're able to see even within a prostate where the tumor actually is. And in addition, we have the treatment planning software that allows us to really deliver the radiation down within about a couple of millimeters of precision. Machines are able to monitor where the treatment is going, not just between treatments, but even during treatment, which is a pretty big advancement. So, I think about our ability to go from 9 weeks of treatment, sometimes 44 treatments Monday through Friday, where there's a large cloud of radiation is going towards the prostate, now to sometimes 5 or fewer treatments where we're really just targeting the tumor. It's like, that cell phone to an iPhone over the last 30 years. It's a big advancement in my field.
So the first thing, so if I were to, again, I'm thinking a little bit more like a layperson than I am as a healthcare professional. The first thing is, okay, I'm going to Dr. Lischalk, and what's his ability to see the tumor properly? So the first thing is good imaging. And you're saying, yeah, this is better than it kind of never has ever been before. I'm impressed with MRI technology, right? In the urology space. It's like, wow, this is, it's not perfect still, because a Pyrat 5 every now and then comes still as a Gleason 6, for example. But damn, that doesn't happen that often. Once it's a Pyrat 5, is either, it's more aggressive. PSMA PET scans. Wow, you can see so much. Same thing with the technology that you use to see where the tumor is. Is that technology different than the MRI and PSMA? Do you have your own technology specifically for SBRT? How does that work from that perspective?
Yeah, so you're absolutely right. It really starts with your imaging. It really starts with seeing the tumor in a more granular level. To use just CT scans in the pelvis to be able to see where the prostate was. And it really just looks like a circle, a gray circle, and that's all you're seeing. With MRIs, you can actually really hone in on the definition of the tumor within the prostate itself. And like you said, you're seeing a Pyrats 3, 4, 5, sometimes nothing. And that's important information. And that really helps things all the way upstream before you even get a biopsy. That's really helping the urology group to see and where to biopsy itself. But it also helps me to be able to target where we're treating when we're treating these patients. So once you get that MRI, we actually use it during our radiation planning process. So this is a really personalized process for patients. We're getting imaging to be able to see where the tumor is in the prostate and also the surrounding structures, bladder, rectum, penile bulb, various structures that are normal, that don't harbor any cancer, that need to be avoided as much as possible. MRI helps us see that. And so once we get those planning images, it's then my job and the job of a physicist who helps me create a radiation plan to create a personalized plan for a patient. And so this is really personalized down to where the tumor is in the prostate itself and the surrounding structures. So once you get that software, or once you get those images, you can use our software to essentially bring radiation in from a variety of different angles to just target where the tumors are in the prostate. And then the delivery of that is also done by a very advanced machine that we use called the CyberKnife.
All right. So clearly, you have to know what you're targeting. If not, then all bets are off, right? So, and the technology is probably as good, if not way better than it's ever been. Can it get better, John? The imaging, in other words, I'm looking at my son playing video games. It's a whole lot different when I play Tecmo Bowl back in the day.
Yeah, it's not Frogger anymore, I guess.
These are they're almost really looking like actual football players.
Yeah.
So is it going to get to that point? I'm assuming perhaps even with the AI or something where you can see the actual tumor, even some of the features of the tumor. I don't know.
Yeah, I think so. I look at the future of this in two spaces. And the first space is all the way down at the genetic level. And so I think we're at the beginning of a change in how we look at prostate cancer. We've been doing for the last 20 or 30 years the same way to categorize different types of prostate cancer. We have low risk, intermediate risk, high risk, and it's based on the PSA, the Gleason score, grade group, and clinical exam. But in each of those realms, we've gotten a lot better at figuring out what a cancer really is and personalizing treatment to that type of cancer. So, for example, genetically, the Gleason score, if you think about the Gleason score, what is that? It's basically a way to categorize how nasty the cancer cells look under a microscope. And so a special doctor called a pathologist will look at that and basically rate these things from 1 to 5. But there's no microscope that can see DNA. And you can't see all the way into that level where you're saying, okay, so I know this gene predisposes a patient to a more aggressive type of cancer. You can't do that on a microscope, but there are tests now available where you can interrogate a cancer specimen or a biopsy specimen and see if there are genetic or epigenetic features that are correlated with more aggressive types of prostate cancer. And I think that's going to help us both figure out who needs treatment at all and who needs treatment that's done more aggressively, where we can amplify treatment. So that's one space where I think in the next 5 to 10 years, we're going to change the way we look at prostate cancer categorization in a big way. And that's one space. I think the second space is going back to the imaging, the MRI. Right now, we're still looking at treating any areas that have cancer in them within the prostate, but there might be a way to deliver focal radiation therapy just to the area we see on the MRI and basically just deliver a smaller dose to the surrounding areas. And that allows us to kind of de-escalate radiation treatment that's closer to the organs that are important, like the bladder and the rectum. So those are just two spaces where I see the future really changing, becoming more personalized and more targeted.
I learned from John Haas. Even I tell people you should be confused. I'm in this space for over 20 years and I'm still learning a lot, actually. I didn't know that focal SBRT, the focal elements of that, right? Because that's why people gravitate to SBRT, meant that you're still treating the whole prostate, not a section of the prostate, not the tumor. I've learned that within the last year only, embarrassingly, because I didn't think. I should have thought it out a little bit further. Because for me, it's like, okay, are you a candidate for SBRT? Great. I see patients, they do amazingly well after SBRT. Go do SBRT. But I thought it was more focal. So are you saying that perhaps in the future you could be even more focal than you already are? In other words, with SBRT, maybe you could hit half the gland and not the whole gland. Maybe if we can really identify the actual tumor, maybe just a tumor and a little bit more outside of that tumor. And is that what you think will happen?
Yeah, I mean, we're actually looking at opening trials in that space right now at NYU. I think what's really cool about radiation is that you can really sculpt the radiation dose to areas that you are more worried about. And this is something that we're doing in a trial that I'm running, where we're treating folks in 2 treatments. What we're doing is we are treating the whole prostate, but if we see a spot that's within the prostate that's identified on the MRI, and that harbors the more aggressive variant of cancer, particularly if the genetic component to the cancer is more aggressive for certain patients. We're going to escalate radiation dose to that area while delivering kind of a lower dose to the rest of the prostate. And in radiation oncology, we think about doses delivered to different areas in a kind of a different space. So if you have more aggressive or gross disease or a large volume of disease, we know that we have to get to this dose, maybe a little bit higher. But if there's lower grades, smaller amounts of disease elsewhere, it may not take that same dose. And being able to do that, kind of differentially spread the radiation dose to where it needs to go and avoid other areas, you might be able to lower the side effect profile dramatically to certain organs that are adjacent.
Let's take a step back for a second. When we talk about a dose of medication, a pharmaceutical, we say, well, take 20 milligrams versus 10, or 100 milligrams versus 50, whatever the numbers are in whatever pharmaceutical. What are we talking about when we're talking about radiation and SBRT? Why not? And I'm at risk of sounding not that smart here, but again, I'm thinking, if I'm the patient, why not just hit the tumor with heavy doses of radiation? Isn't that the goal, to get rid of the tumor? So what are we talking about here when you say, well, lower the dose or increase the dose? What does that mean?
Yeah, radiation dose and exposure is a really interesting concept. There's a lot of talk about exposure, especially when you're getting diagnostic imaging like x-rays or CT scans. But I think one thing that folks maybe don't realize is that flying from LA to New York has about the same level of exposure to radiation as getting a CT scan. And so we live in the world, we're constantly exposed to radiation everywhere. It's just a natural phenomenon. And so the level of doses that we're using in radiation to treat and cure cancer, they're orders of magnitude higher than what you're seeing if you get a CT scan. So a lot of folks I see get a little worried that they're getting a CT scan after they got radiation. But that's honestly like a drop in the bucket. It's not even close. So we're using really large doses of radiation when we're treating cancer. And the dose level is something that we use the unit gray to describe, so GY. But it's also related to something even more complex, and that is the radiobiology of a given tissue. And so, like, let's use, for example, 5 gray delivered in one treatment is much different than 5 gray delivered over 5 treatments. If you deliver a big dose of radiation in a single treatment, the cancer is seeing that dose a lot harder. It's hitting them a lot harder. And there's a variety of reasons for that are related to the genetics and the vascular supply and certain things that we're still trying to figure out and understand. But
we also make the argument, so that we understand exactly what you're saying. So you said 5 grade treatment done once is much different than 5 grade treatment done 5 times.
Or I should say 1 gray delivered 5 times to get to that 5 gray. And so, in both situations, the total dose of radiation delivered is 5 gray.
Right.
But the way that it's delivered is very different.
Gotcha.
And so, we have this concept of the biological dose that a given cancer will see. And the bigger dose that you delivered, the bigger dose that you deliver over a shorter period of time makes a more significant impact. And so that was actually one of the reasons why we originally decided to go from these 44 treatments to prostate cancer all the way down to 5 treatments, and sometimes fewer now, is that we thought the way that the prostate cancer saw the dose, it might be more sensitive if you delivered it in big doses over a shorter period of time,
as opposed to smaller dosages in a longer period of time.
Exactly.
So are we going to get to the point, John? It's okay. I won't hold you to it. Are we going to get to the point where it's like, hey, just one treatment of SBRT. That's all you need. Are we there yet? Are we there yet? I'm talking about kids. Are we there yet?
We're at 2 right now. So the trial that I'm running is looking at delivery of 2 treatments once a week. There's been a lot of talk and a lot of research recently on the burden, the financial burden of oncologic treatment on patients. And it's huge. I mean, for a radiation oncologist, bringing somebody in Monday through Friday for 44 treatments, like, that's a part-time job. And I think Stanford and UCSF have done a lot of good research into showing that radiation treatment can be the most burdensome financial impact on a patient if you're coming in for 9 weeks of treatment. So, there's the toxicity from radiation, the urinary changes, and the rectal irritation, but there's also the components that we don't always measure in trials. And that's the burden of a longer course of treatment on the finances of a patient and the quality of life. So I think bringing these treatment lengths down has been a panacea for a lot of folks.
It goes right along with my personal philosophy. I think the philosophy of most people that do what I do, which is like less. How can less be more, right? How can less be more? Fascinating. So then it leads me to the next question. How can you personalize the treatment more? Who needs 5 versus 2 versus 1? Who needs SBRT with androgen deprivation therapy, which no one really wants? Who can forego the ADT and just do SBRT? And in salvage situations, for example, what does that look like? Where patient probably had a prostatectomy, maybe SBRT, right? If they have a positive lymph node. One of the things, I'm bouncing around a little bit, stay with me. But one of the things that I'm impressed with SBRT is when they've had a prostatectomy, let's say, and they find a lymph node that's positive, and so the PSA is going up, lymph node, PSMA showing this lymph node is positive. That's all we can see based on the PSMA. You hit that lymph node with SBRT, and that kind of takes care of it, or should take care of it. I find that fascinating because it's like almost no harm, no foul. I haven't seen cases like that where patients have had side effects issues. So going back to personalization, where are we with that now? Where are we going with that in the future?
Yeah, it's a great question. I think, let me start by tackling some of the questions related to ADT. I think, ADT has been a thorn in the side of everybody for prostate cancer treatment for time immemorial. And we have a lot of data from an earlier era of radiation that showed that the ADT was just critical, certainly for high-risk patients, but also for some types of intermediate-risk patients. And so,
which showed that ADT combined with radiation was more effective in controlling the cancer than just the radiation alone. This is a conversation that you guys have had, and I have with patients. Look, I don't want ADT. I understand why you don't. But the data seems to be clear, at least with the type of radiation we had back then.
Right, exactly, back then. So when we were doing these trials, one of the big problems with oncologic treatment is that our trials are always in the past compared with the evolution of treatment we have. We're always one step ahead in imaging and biopsies and pathology analysis and radiation techniques. But all this fancy stuff is really not helpful unless we know what to do with it. And the only way we know what to do with stuff is by doing trials. I think this was one of the challenges with, the COVID pandemic. You saw all these trials needing to be conducted, but at the same time, people were suffering. And so it's one of these things that, unfortunately, what we have right now is the gold standard is randomized trials for cancer treatment. And all the randomized trials historically have shown that ADT is still necessary for certain types of treatment. Now, we've gotten rid of it for certain intermediate risk prostate cancers, like favorable intermediate risk, so the lower end of the intermediate risk spectrum.
Just from a histological perspective, not from a genetic perspective, correct?
Exactly, yeah. And that was done by a colleague at NYU, Dr. Zelensky, who really pioneered separating out intermediate risk.
A colleague at NYU now, I must say, who goes from the Yankees to, who? It's like, wait a minute.
Yankees to the Mets?
To the Mets or so. Well, when you look at the rankings now, I think the NYU could be the Yankees, or at least Boston and the Yankees, right? Yeah, that was amazing. Before we continue, though, and this is not an advertisement, before we continue, let me tell you through that. No, that's not it. So John Haas said, well, here are my Mount Rushmore radiation oncologists. So Zelensky was one of them. My question is, who are yours? Who are your 4, all time?
It's going to be John Haas.
Is he your boss by any chance? Is John Haas your boss? Like, who's the best urologist ever in the history of urology? Dr. Herb Lepore. Who else?
Exactly.
Right.
Well, I mean, we definitely have one of the same ones, Dr. Zelensky. I remember
Yeah.
when I was in residency, he was giving lectures on prostate cancer, and that's kind of how I learned, everything I know. It really started there. I've been really lucky and fortunate to work with a lot of really spectacular radiation oncologists. I trained at Georgetown with Dr. Sean Collins, who also pioneered, along with Dr. Haas, the use of SBRT. Now getting to work with Dr. Zelensky, it's just been, I've been very fortunate to work with leaders in the field for
Makes such
prostate
a
radiation
difference.
oncology. It really does. Yeah, it really does.
Mack Roach is up there.
Oh yeah, yeah.
Mack Roach.
Yeah.
You gotta love the personality. It comes with the personality, though.
Yeah, a few years ago, we actually had to debate each other out in Arizona. And
You debated him?
Yeah, I mean, I wouldn't say debate might be the perfect word for what happened, but, I think, no, he was very kind. It was more of a conversation about using SBRT, actually, for a lot of different types of prostate cancer. And, he's pioneered a lot of this as well, using CyberKnife and brachytherapy, different radiation modalities. He's been kind of leading that space from the West Coast for a long time.
Yeah, for sure. All right, sorry, folks. Listen, this is sometimes it does feel like we're just having coffee somewhere, and you're just eavesdropping. You just happen to be there. But we'll get back to the topic. Personalization with SBRT. If you can go on with that again.
Yeah. So looking at where we are going with ADT.
Thank you for watching the Dr. Geo Prostate Podcast. Take a proactive step and improve your health and vitality with the Prolon Fasting Mimicking Diet FMD, a 5-day, plant-based program developed by Dr. Walter Longo, designed to mimic the effects of fasting without the challenges. Prolon helps activate autophagy, reduce inflammation, support weight management, and promote overall longevity, all while nourishing your body. As a special thank you, you can access the Prolon kit for just $148. Use the link below to get started. Empower your journey to better health today.
So we've gotten rid of it for a certain subset of patients, but we know from the data that it was older radiation technique that we were using when ADT was beneficial. The question is, as we just talked about, radiation has gotten so much better. So now that we're using an iPhone 15 to treat prostate cancer, do we still need to have ADT? And that's the real question. And that's actually a question we're trying to answer right now with a randomized study out of NYU spearheaded by Dr. Zelensky. And so we're hoping to put this question to bed in the era of SBRT.
Do you need it at all, or who
At
needs it and
all.
who doesn't?
At all in intermediate risk disease. And what's really cool about this study too is that we're using the older designation of intermediate risk, but we're also collecting the genetic profile for all of these patients so that when we go back and analyze the data, we can see which signatures are there that may correspond to people that may need it or may not need it.
What definition are you using for intermediate risk?
So we go by the NCCN guidelines. So we're looking at PSAs 10 to 20, having a Gleason score 7. So that's grade group 3+4 or 4+3. And
so it doesn't matter if it's considered low intermediate risk or high intermediate risk. It's under one category.
So all of these patients for this trial would be considered high intermediate risk. Okay. Yeah, because that's the space where we're still advocating for ADT.
Right.
And so we're looking at that entire group of patients and seeing if we can just wipe it out in that setting.
Beautiful. I love science, as I've been at, again, in academic institutions for the longest, even in the natural world that I spend a lot of time in. I'm really critical about, the scientific methods that are used to say this works or that does, or the lack of science, right? I love science. But sometimes it holds us a little bit back, right? Why? We just looking at intermediate risk, this Gleason 7, we want to know. Hell, I want to know if it's a Gleason 8, Gleason 9. Is there a difference? Because there could be such thing as, based on Deciphers that I've seen, some of those outcomes, low risk Gleason 9. I know that sounds crazy, but so then if it's a low risk Gleason 9, let's just say, I don't want to undergo ADT, right? I just want to undergo SBRT. So it's almost like science, you do this great trial, but it's only for this particular kind of patient. These other patients we still don't know. I would love for it to be like, like across the board, right? Like, let's see where we're at with all these patients that are diagnosed with different Gleason scores.
Yeah, I agree. I mean, that goes back to what we were saying. I think that the way we're going to categorize people generally, it's going to change. I think it's probably going to change in the next 5 or 10 years. We're not just going to be looking at the classical stuff that we used to do. We're going to be taking into consideration MRIs for the clinical staging, and we're going to be looking at genomic scores much more closely. It's already happened in other types of cancers like breast cancer. It's really included now within the staging within breast cancer. And so it's only a matter of time within prostate. So like you said, maybe the categorization for somebody that had a Gleason, higher Gleason score may actually genetically look less aggressive. Or even more importantly, that we have somebody that has a lower Gleason score, but has sky high genetics. Those are the patients we really don't want to miss, because in those cases, we might be undertreating them dramatically.
This is why and oftentimes my colleagues, one of the things with naturopathic doctors or functional medicine doctors is that we want to get data, and sometimes we overdo it on just collecting things that, well, I don't think I collect things that information that I don't do something with, right? It doesn't help me help them more. But sometimes in our world, you just keep collecting and you don't know what to do with that information. But from a genetic perspective, no harm, no foul. Gleason 6, let's get a Decipher. Some of my urology colleagues are like, why are we doing this? A Gleason 6? I said, because we don't know. What if it's a high risk Gleason 6? Even intermediate risk Gleason 6 will, I don't know if that means that they can't be on active surveillance, but at least I will tell them, hey, you can't disappear like many people on active surveillance do, right? They just, okay, Gleason 6, I don't have to worry about it. Oh, some people are saying that this is not even cancer. All right, yeah, I don't have to worry about PSA or things like that, right? Well, that will give them more information. So I think to me, it's like, why not just get it on everyone? And relatively the cost is low, and it could be even lower if we don't overtreat.
Yeah, I'm a big proponent of getting the genetic test on most patients. And I think as time has gone on, I've gotten it on more and more folks. We're actually working with a company that has developed one of the genetic tests to look at a lot of really granular information within our patient population, to dive into some of the genetic profiles of certain things like, are there genetics that correlate with certain types of histological features on the biopsy? Is it related to toxicity? Is it related to outcomes? I mean, there's a lot of stuff there that we really need to explore. And that's why having a collaborative, multidisciplinary team working with some of these really innovative companies to figure out, what all this means is critical.
What company are you using to do the study that you're doing? What genetic company?
So mostly I work with Decipher.
Decipher. Okay. Good. They seem to be, we just got back from the AU, and not just in May, and it's like all the genetic lectures were really Decipher lectures. So I went to those guys and said, are you guys like paying people to talk about only Decipher? Truth be told, they put a lot of money into research, and so they've done it right. And I'm not sure that it's similar to the other companies, so I've used them as well, but they've done it right. John, here's the patient needs to know. Part of the confusion with patients is, holy cow, there's so many options for me in my cancer. Well, radiation then. I'll do radiation. No, it's not just do radiation. There's a lot of options within radiation. And so this guy tells me this, the other guy tells me that. We're talking about external beam radiation. We're talking about IMRT. We're talking about proton beam radiation. And certainly, I got to say, some of the advertising is very appealing when you listen to some of these. Where do I sign up for that? But Geo, you don't have prostate cancer. Still, this sounds so good. I'll do it anyway. It's such good advertising. So how can we bring more clarity to the patient as to, and I know that could be another podcast in terms of if it's this great as that, if it's that great as this, but how can the patient, when we talk about a lot of talk about shared decision making, right, between the patient and the physician, I love that. But the patient needs to be empowered with good information, not just advertisements.
Yeah, that's really important. I mean, the landscape can be really confusing. There are a lot of different types of radiation. I think the first thing that I try to do when I'm seeing a new patient is figure out where they're at from a medical standpoint, how they're feeling, how their function is, and then kind of what they're interested in getting out of from their treatment or avoiding. And so, I start from the very beginning. Let's take the most complex situation, which happens to be low risk prostate cancer, or maybe a favorable intermediate risk prostate cancer. The first step is, do I need to do anything at all? Is this something that I can undergo active surveillance, or should I move more for treatment? And that's the first step in kind of deciding. And that's going to involve, patient preference, family history, genetic profile, where are they at on that spectrum? Is this going to cause a lot of anxiety if I keep watching this? Do I want to keep getting repeat prostate biopsies to monitor this? Active surveillance, the operative word there, is definitely active, as you highlighted. And so you can't just not do anything. So that's the first step, figuring out which direction you want to go there. If you do decide on treatment, the next branch point, I think, is going to be surgery or radiation. And both of those really have so many different subdivisions. It does get more complicated. But I think in general, deciding whether you want to go with a urological approach or a radiation oncology approach is important. Now, this is, again, where I think the function comes into play, or concerns. There are different side effect profiles and quality of life that you see after each of those procedures, and getting a sense from a patient how they're doing beforehand and what they're worried about long term helps guide them towards different directions. Sometimes there's not really an option for surgery just because of issues with anesthesia, maybe other medical comorbidities, and they kind of lean the other direction. And then there are sometimes situations where I want to move somebody more towards surgery. A good example of that would be, let's see, a 65-year-old who has really bad urination, is getting up 6 times a night, has a big prostate, has some cancer. It can be treated with radiation or surgery. I try to steer them oftentimes towards surgery, all things being equal, because it's 2 birds with 1 stone. So
yeah, radiation is not going to make the urination problem better. It's going to probably make it even worse, perhaps.
Exactly. I mean, I think that both techniques cause urinary changes. And if you looked at the randomized prospective data, now we have almost 2 decades of experience, the urination difference is different. It's more obstructive symptoms with radiation. And with surgery, you can have more leakage and sometimes pad usage with surgery. Now, that's not true for everybody, but if you just look on the average, that's kind of what you're seeing between the two. And so understanding upstream of where a patient is beforehand really helps avoid a lot of problems downstream. And then once you get into the subdivision, I'm not going to go into the urological different procedures like cryo and prostatectomy and robotic and et cetera, et cetera. That's not really my area of expertise, but suffice it to say, there's a lot of different approaches from a surgical standpoint, just like there are from a radiation standpoint. So like you said, when I think about the different radiation modalities, you have the external radiation treatment and then the internal radiation treatment. Internal being brachytherapy. Even brachytherapy has 2 different types: high dose rate, low dose rate, temporary, permanent. With an external beam radiation, you have IMRT, you have SBRT or CyberKnife, you have proton therapy. So there are a lot of different techniques. When there are so many different modalities of treatment, the first thing you want to do is kind of rely on the evidence. So what's the randomized evidence? And is my patient somebody that would have been eligible for that?
But they're not. What I want to see from a research perspective as a patient is head-to-head trials. Have you studied proton beam with CyberKnife or SBRT? We keep calling it CyberKnife. Again, is that it's almost like saying tissue paper Kleenex a little bit. But so SBRT, and there's several companies that do SBRT, to be fair.
Right.
But SBRT versus EBRT, like, are there random head-to-head trials?
Yeah. We going back 2-minute history on SBRT. In the mid 2000s or so, we started exploring using SBRT, which fundamentally is just high dose radiation delivered over a short period of time in a very precise fashion with really complex, well-designed plans. This type of treatment kind of grew in the 2000-ish range, kind of when IMRT was being utilized more and more widely. SBRT was just starting to be explored. And it was back then where we had it being used for a variety of different cancers, including prostate cancer, lung cancer, liver cancer. And it's still being used for those other types of cancers. But if you fast forward 10 years, maybe mid 2010s, 2010 to 2015, we started doing exactly what you said. We started comparing the data head to head. We started comparing SBRT with IMRT. The trials that have really spearheaded this have been conducted in Europe. One was in Sweden, one was in the UK, and actually both of them have been published now. And so we do have data comparing IMRT with SBRT, and it looks like it's pretty much a wash, that the cancer controls are pretty much the same. Side effect profiles are fairly similar. There is some subtle differences in when the side effects happen, not surprisingly, because 9 weeks of treatment goes on a lot longer than 1 week or 1.5 weeks. But the data is starting to show that SBRT relative to IMRT is a very competitive modality. And all things being equal, I don't know a lot of people that want to go 9 weeks of treatment over 5 treatments, but some people do go that route. In terms of proton therapy versus other types of treatment, there was also a study that looked at protons versus IMRT, though that one has not yet been published. So the jury's out on that.
Ooh.
Proton therapy is something that I have a lot of experience
Stay
with.
tuned. What I know about proton therapy is, man, it requires a football field to put this together. So even that alone, the cost from that study that we don't know about, you said EBRT versus proton. Is that what the study?
Yeah, IMRT versus proton.
IMRT. Yeah. The difference has to be so much, in my opinion. Not only it has to show that proton is better, but by a significant amount, just because of all it takes to bring this equipment together and the facility together. Is that right?
Yeah, these facilities. So first of all, for about 50 years, there were only 2 proton centers in the U.S., one on the West Coast, one on the East Coast, right? So limited access for folks.
That's right.
Historically, we've been really interested in using protons for certain types of cancers. Probably the most common type is pediatric cancers, so childhood brain tumors and other malignancies, sarcomas, etc. These facilities then kind of there were a few more that were built in the early 2000s, maybe 5 or 6 more. And the ones that were built, these were expensive. These were $200 million plus. This was the most expensive facility that an academic center had in some situations. Now, the cost has definitely come down. A lot of these facilities now, somewhere between the $30 and $50 million range, but that's still quite a bit. When you compare it to other types of radiation equipment. I think, most cancer centers will like to have that equipment available to them so they can offer it to patients that are good candidates for it. It's just not clear right now, because we lack the randomized evidence, who those patients are. But it is going to be something that we see evolve over the next couple decades.
Cool. Final words, and how can people find you if they want to see you as a patient? And thanks for being on. I really appreciate your time and expertise here. I can't wait for the results of your study with using genetics and see, who's a candidate for what. I am super pumped for it. So then
thanks for the invitation. It's been awesome. You're doing a lot of really important work here, getting the word out. So
getting the good word out.
Getting the good word out.
The good word. Yeah. That's part of, you asked me before, how did you start doing this? Why did you? Well, part of the reason is there was a lot of bad information out there around these topics. So it's like, how can we get, I'm a big fan of shared decision-making. Well, you need to have good information, accurate information before you go in and, start hassling your doctor as to, no, I want to do this. Well, is that even reasonable? I'm sorry. Go ahead.
Exactly. No, you're absolutely right. The internet can be a big rabbit hole in a lot of these situations. So I'm the medical director at the NYCyberKnife Center in the Upper West Side up on West 66. So that's where I am the majority of the time. And we also the director of research in our Long Island Radiation Oncology department. So happy to, if anybody needs any help, I'm happy to see patients there and work with Dr. Haas, who you've had on here, who's the chairman of our department and really spearheaded a lot of this treatment from soup to nuts over the last decade and a half.
That's right. Great expert. He will be. He's too humble to say it, but at the end of the day, I think he will be up in Mount Rushmore and really a humble guy, and he would never admit to it that he's who he is. Well, thanks a lot, John. I really appreciate your time and expertise here and sharing the information, and particularly sharing the information of where it's going from a personalization perspective. I think that's the way to go for sure. To find you, I'll have links to your website profile at NYU. Is that the best way?
Yeah, there should be a contact number on there, and there's also links to the different trials that I'm involved in, so that should be all visible on the profile.
Excellent. Dr. Jonathan Lischalk. Yeah, I almost said Haas. Lischalk. How do you guys? So it's Dr. Lischalk and Dr. Haas. That takes care of any confusion that goes on in the office, right?
Yeah, for the most part, yeah. Thankfully, we don't have the same letter start for our last name.
That's right. Thanks again, John. Be well.
Take care.
Thank you, everyone, for joining me for this amazing episode where we talk about radiation and SBRT for prostate cancer. As you know, it's all about staying informed and staying well informed. And this is what we are here to do. Take good care. Much love. And I'll see you at the next episode. So long.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more. The Dr. Geo Prostate Podcast is here to provide you with information and support on your prostate health journey. We are introducing our exclusive membership where you can get even more value from every episode. Every episode comes with detailed show notes, breaking down the key points so you don't have to take notes while listening. You'll also get curated transcripts so you can read and revisit everything you just heard, perfect for learning at your own pace. And for every episode, you'll receive a handy list of resources, products, links, studies, and tools mentioned in the show, all in one place. That's not all. Members also enjoy special discounts on hand-picked products to support their health and wellness goals. And there's more. Members get exclusive access to Dr. Geo's monthly Ask Me Anything, where he answers questions submitted directly by the community. All of this for just $19 a month, or save 20% when you pay annually at only $182 a year. Smarter listening, deeper learning, better health. Join the Dr. Geo exclusive membership today. Start getting more from every episode.
Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.